Welcome to this continuing education activity titled Considerations Around Establishing a PD-L1 Laboratory-Developed Test. In this activity, we will describe how laboratories are establishing a PD-L1 laboratory-developed test, list the key considerations around establishing a PD-L1 LDT, and discuss some potential limitations when using a PD-L1 LDT. At this time, I would like to ask each panelist to please introduce yourself.
My name is Dr. Yin Rex Hung. I'm a lung and soft tissue pathologist at the Massachusetts General Hospital in Boston. And I'm also the medical director for the immunohistochemistry laboratory at MGH.
I'm Jeffrey Schulte. I am an assistant professor at the University of Wisconsin, where I sign out on the thoracic and bone soft tissue services. I'm also director of immunohistochemistry and histology laboratories here in Wisconsin, and I've been involved in the validation of PD-L1 testing in our laboratory.
My name is Mamata Chibukula. I'm a director of breast pathology services and director of immunohistochemistry laboratories at Mills Peninsula Medical Center, which is part of the Sutter affiliate in Northern California, in Burlingame, California. And I'm part of the bringing in the PD-L1 to the laboratory validation process. I'm also part of the anatomic pathology division of Sutter Healthcare, where we are trying to bring in all the centers to have a uniformity, at least a certain way of uniformity in ordering tests.
Tell us, how do you perform PD-L1 testing within your own institution?
So at the Massachusetts General Hospital, we perform PD-L1 using the clone E1L3N from cell signaling. And the staining platform we use is LICA-Bond. And so we use E1L3N as the PD-L1 clone and the whole package as a laboratory developed test.
So you're using that for all different tumor types?
Correct. In very rare situations in which because we only have LICA-Bond staining platform at MGH, we are unable actually to perform, let's say, the DACO22C3 or the Ventana SP263 or SP142, because we actually do not have those machines. And so if the clinician insists on needing those tests using exactly the companion diagnostics, we actually have to send it out. But I would say for 98, 99% of the time, we perform our own PD-L1 using a laboratory developed test.
Dr. Schulte, how about at your institution?
So at our institution, we use Ventana systems for our stains, and we actually use all of our PD-L1s as lab-developed tests utilizing clone 22C3. We've been doing that in lung cancer for at least probably 6 or 7 years, and we do that reflexively. And so every new diagnosis of a lung cancer, I should say of a non-small cell, we reflexively order PD-L1 testing. And more recently, we have brought in PD-L1 testing for our gastrointestinal tumors, as well as our gynecologic, mostly cervical squamous cell carcinomas.
Dr. Shivakula, how about at your institution?
So we use PD-L1 testing in-house. We do it in our laboratory. We use the 400 LICA-Bond max, and we use the 22C3 antibody, which is labeled as LDT, and it's called the LDT kit. That's the antibody kit that we use.
So Dr. Hung, given that you all run the LICA platform, tell us how the decision was made to select the antibody clone that you are using currently.
The history of how we adopt the PD-L1 testing at Massachusetts General Hospital. In fact, our sister hospital, Brigham and Women's Hospital, they adopt PD-L1 testing. They have the DACO staining platform, but they use the cell signaling E1L3N clone just a few months earlier than us, I believe. And so I would say that within a pretty short time, we chose that clone partly because I think we heard good performance from our colleagues, but also in terms of cost consideration at the time as well.
Dr. Schulte, at your organization, how did the decision come about to select the antibody clone that you are currently using?
So we picked 22C3 based off of, at the time, clinician ordering preferences. Before we brought PD-L1 in-house, that was the most commonly ordered clone by our thoracic oncology group, and so we brought that in-house. And what we've essentially done with other groups of malignancies is we say, okay, we already have 22C3 in-house working on our platform. So LDT, when we bring in the new group of cancers to study, we just essentially start with the 22C3 because we have it and we see how it performs. And we make modifications as needed, but we've been able to get excellent results with our comparison to outside reference laboratories by just tweaking our existing protocol that we use in lung cancer. So we've tweaked it to use in gastrointestinal, we've tweaked it to use in GYN, and that's been working. And so that's how it was done here.
Could you elaborate a little bit more when you talk about tweaking protocols, whether it's for lung cancer or for GI?
Concentration of the antibody, various, amplification steps. So they're usually very, very small, subtle changes. But every once in a while, we may find that the background's a little dirty. You might want to dim down the stain just a little bit. And so nothing major, but just slight modifications here and there to the protocol.
Dr. Shivakula, how about at your institution? How was the decision made to use the antibody clone that you selected?
Originally, the 22C3 was approved for the DACO machine, the platform. But since we didn't have the DACO, and so what we did was we tried to validate it on the Ventana UltraView. And at the time, initially, they did not approve the validation process, the Ventana. So meanwhile, things have changed and new LDTs were coming up. And that's when they became platform friendly with us. And we started, the Leica offered the validation process. And that's how we got into the Leica Bond Max. And we do have the LDT version of it that has come up now. So everything fell in place. But initially we had a little bit of struggle, but we wanted to keep the 22C3 clone.
So in your experience, have there been any particular limitations of using an LDT as opposed to essentially running the companion diagnostics when it comes to PD-L1 testing?
Everything we do is a laboratory developed test with PD-L1. And the struggles that we've encountered mostly pertain to cleaning up the background, making sure you're getting rid of nonspecific staining, just making sure that you have a clean, crisp stain that is easy to interpret. Myself as IHC director, I can look at a stain and say, oh, that looks good. But what I have to be mindful of is how are others going to interpret this? Is it clean enough for them to read, the rest of my colleagues to read? Other challenges that I've encountered using specifically LDTs is that when you go to do a comparison, sometimes it gets a little tricky when you're validating a stain. You send it out to a reference laboratory and they may be following, likely they could be following a companion diagnostic test, and you would hope that you would get the same result. And sometimes, depending on where you send it, the result comes back maybe reported a little differently, which makes your interpretation challenging. If we're validating a study as an LDT and we want to focus on making sure that we have very tight control over our stain that's performing just as we want. If we're developing something, say, using a TPS score, we may determine up front that we want a range of 10 to 20% as being considered in control or acceptable comparison, I should say. But if you send it to a reference laboratory, they may say PD-L1 greater than 1%. And so how do you know, unless you review that slide, how do you know how comparable those stains are? So that's been a challenge in doing these validations. And I think that's probably a challenge regardless of if you're doing a laboratory developed test or following a companion diagnostic. That's been our experience here, is just without using a companion diagnostic test and following the exact protocol, you're creating your own. Cleaning it up and making sure that it's interpretable by all is a challenge, and then doing that comparison with an outside reference laboratory has also been a major challenge.
Although it feels like it's been a long time, but such a short time in the last 3 years, we faced a lot of challenges for the PD-L1 testing. And when the initial trial data has come, the oncologists were pretty familiar with the methodologies that they used, and 22C3 was the striking one. They wanted to be specific that we are using the 22C3 for interpretation of the PD-L1. Then in the pathology world, the LDTs have come and different clones have been validated and all that. So what we did was, one of the challenges we had, put in our reporting system. We do put in our reports, all the details of the clone and the platform that we use. And the strong validation definitely is one of the strengths of our PD-L1 testing. And also, we do our proficiency testing through the lab for the past 2 years, and we have successfully passed all the CAP proficiency tests. And those are the measures of what we are doing pretty good in our laboratories.
I would say, given that at the Massachusetts General Hospital, we only had a staining platform, we just cannot do companion diagnostic testing. So by definition, actually. But then I think the development of LDT in a way allow us a lot of flexibility. So in that sense, it was actually very powerful. So I actually do not think that in terms of comparing between LDT and companion diagnostic, that in that sense was limited. But in terms of PD-L1 testing in general, PD-L1 immunohistochemistry is a semi-quantitative biomarker, right? In which in the space of non-small cell lung cancer, TPS score 1% matters. 0.5 versus 1% is actually a clinical decision point, right? 40 versus 50% can be a decision point. And so it's all reminiscent of, in terms of breast cancer, HER2 testing, in which, having 0.5% versus 1% versus 10% breast cancer cells with hormonal receptor expression can matter quite a bit. And so I would say that creates challenges on both in terms of validation, as well as in terms of proficiency testing, and how can we make sure that the PD-L1, the performance of the immunohistochemistry as we first validated years ago, how it continues to perform consistently. And so at the Massachusetts General Hospital, we actually do use tissue microarray with known cell line with PD-L1 known expressors, so that we would keep track of the expression over time. We actually stain those tissue microarray once every week or once every other week, and I actually will keep track of the expression over time and comparing the expression of the PD-L1 every week. And then we also perform being involved in the CAP proficiency testing, making sure that our results are consistent with the as expected, actually. So I think there are ways to overcome these challenges, but I think it certainly made it harder than your typical biomarkers that were asking yes or no question, because in this case, because it's semi-quantitative.
Dr. Shivakula, what have been some of the challenges with scoring using CPS?
The challenges have been in the metastatic setting, where you do have bony samples, where sometimes can play a role in the scoring of the PD-L1. In the adjuvant setting, large tumor necrosis is something that is very challenging as well. And small samples can create a problem to count the number of cells truly to give the scoring system. And sometimes for the CPS, we do not have the lymphocytes, okay? So not much of inflammation that we see in the metastatic setting, and that sometimes can create a problem as well. So these are some of the challenges we have seen.
Working at an institution in which the majority of pathologists who were scoring PD-L1 were used to doing so in lung cancer, so by a tumor proportion score. So switching over to a combined positive score was a challenge in and of itself. It's a different way of thinking about scoring. And I can tell you that if you try to just distribute a bunch of PD-L1s to a group of pathologists who are more familiar with TPS, you're going to get a wide range in responses for CPS scoring. And so I do think that both for TPS and CPS, if you're not familiar with it, I think there is an element of needing some education as to actually how to interpret the scoring system. What cells do you actually count? What are inflammatory cells in the tumor? What are inflammatory cells outside of the tumor? And that's been an issue, especially, and I think if you dial into some of the discrepant scores, you often find that some people will say, well, the CPS wasn't as high as I thought, because all the lymphocytes only seem to be at the edge, and so I just thought that they were background lymphocytes and not actually tumor-infiltrating lymphocytes. And so you'll get some differences of opinion there with CPS. But I think one thing that we've done to get over this challenge is just sit down as a group when we first start bringing in new tests and say, okay, we have a new group of readers in the GYN group, and let's sit down and look at some of the freely available instructional manuals that exist online and on how to interpret these. Sit down together, look at it as a group, maybe do a little quiz, and then come back together and compare answers, and mostly just to get on the same page. But variation in scoring is a major challenge. But I think, as has been previously mentioned, You get into issues with necrosis, small tumor samples. Those present technical challenges. And if the reader's not aware of some of those technical challenges on small biopsies and with the presence of necrosis, those can also be a challenge.
As a lung pathologist, I primarily do TPS scoring, although occasionally I do receive cases in which patient had tumors as metastases to the lung from head and neck primary, esophageal primary, other sites that the oncologist requires CPS, PD-L1 results. So in my experience scoring those, I found CPS harder, at least to me, not as intuitive, but also takes longer. And so I think my colleague agreed with me that CPS scoring generally, at least in terms of spending time, it takes a lot longer. It can be like 15 minutes for one slide. And so in terms of busy workload for pathologists, I do think there's also a practicality that it takes a lot longer. Of course, we want to do it right, but I think it also, in terms of resource limited, in terms of our time, it certainly can add constraints.
If you've got, say, an esophageal primary that then ends up being a met in the lung, and you biopsy that lung, do you score that using CPS or do you score that using TPS?
So if I know it's an esophageal primary, I score CPS because I know that's what they want. If there's a case that was unknown primary, I actually provide both scores. That also brings up a good question. Sometimes we don't even know what scoring system we might need.
When we get the cell block material, we divide them into 2 blocks, and we do a limited IHC panel. And the gold standard in pathology is always to compare with the primary. And we try our best to evaluate it for the metastatic setting. And depending on that, we try to give the scores.
How often are you getting a request for a tumor type where the scoring system hasn't been clearly defined?
As a bone and soft tissue pathologist, I have gotten requests from clinicians, from sarcoma doctors who request PD-L1 testing on bone tumors, on sarcomas, in which there's actually very limited data on how we think about PD-L1 as a biomarker and whether that plays a role in immunotherapy. In that setting, I think we basically in uncharted waters. And so do we score by CPS, TPS, immune score? I mean, the fact is, I felt like in those instances, the field doesn't know the answer. My clinicians actually don't know the answer either. And so in those instances, I usually just provide a TPS score, and it seems to be okay with it. But I think at the end, it is a very challenging topic in which the role of PD-L1 and how we handle the testing in these unusual tumors is not really well defined.
There is the rare tumor in which, there is an unclear indication for PD-L1 testing and unclear what we should be reporting. One example of that was, especially in my area of expertise, would be mesothelioma. We do perform PD-L1 and we typically report a TPS score. But we do receive requests for other types of tumors. And simply what we do in that setting is sometimes the clinicians provide on their requisition form 22C3. We have it in-house, we perform it. And if they're really kind to us, they'll actually tell us what they want us to score it or how they want us to score it. And so we just report what they ask for. Otherwise, they may request a specific antibody that we don't have or a system we don't currently have in-house. And so we will send that out to the most appropriate reference laboratory that can meet the needs of the clinician.
We are getting the requests in advanced and metastatic settings. That's when we get to see all these rare PD-L1 testing. The point is to, in the report, you give as much information as you can regarding the staining pattern, positive, negative, intensity, what percent of cells are positive. So that's what we're doing.
I want to go back to the topic of validation. What are the actual steps and how long does it take? What are some of the challenges?
Ideally, the steps will be to test a large number of cases. In terms of CAP guideline, we're talking about 40 with 20 positive, 20 negative. But of course, for PD-L1, we're talking about gradations of range of different expressions. And because we want to compare those, our LDT with basically what was already done with, with a companion diagnostic so that we can compare head to head. And so that would be the plan. I think in practice, in order to really make it happen, it's not something that one can done overnight. It takes weeks, if not months, to collect those samples, depending on the clinical volume. And I think that creates one challenge. And so in terms of additional challenges, and I alluded to earlier too, afterwards, once the immunohistochemistry, let's say, is clinically validated as a laboratory developed test and that we can bring it into clinical use, making sure that it performs consistently so that the staining pattern, because if it even changes, let's say 10 or 20% with increase or reduction, that can have dramatic impacts actually on the cases with borderline thresholds close to 1% or close to 50% TPS staining, let's say in the example of non-small cell lung cancer. And so continue monitoring. I think for a long time we were struggling about what's the best way to continually monitoring these cases. And currently we are using tissue microarray with cell line with known PD-L1 expression levels as controls that we do every week. And so that allows us to really monitor it. But before we settle on that strategy, I imagine it can be very difficult.
We went above and beyond the number of cases, the CAP recommendation for validation purposes, and across the board for all organ systems. We have increased the number of cases. And one of the things that was brought up is the continuous monitoring of this. And it is a challenge across the laboratories how to monitor them. And one of the measures, as I said earlier, we are using the CAP proficiency testing for PD-L1, and that is at least giving us a little bit of assurance that that we are performing well. But at the same time, this is a continuous monitoring can be done by the pathologist. Any inappropriate staining, no staining pattern, or any question regarding the scoring patterns. We are reaching out to our colleagues and have a discussion, and that's when we report it out.
I can speak on the topic of kind of maintaining the quality of staining after validation. We participate in the CAP proficiency surveys as well. And I can tell you that, as has been discussed earlier, how do you catch that small deviation in staining? Are you about 20% down from where you started? Are you 20% increase in staining? And we actually had that happen to us. We had a slight drift in the amount of tumor cells and the proportion of tumor cells, specifically in lung. On the CAP proficiency survey, we noticed a drift towards negative staining. And we were able to catch that through participation in the CAP proficiency survey. But what we did then was we actually changed our control that we were using. And so we do use a tissue microarray like Massachusetts General, but what we added to that was different degrees of expression, specifically in lung cancer, of PD-L1. So we have a high expressor on every single TMA. We have a medium or low expressor, I should say, and a null expressor as well. And we actively gather those cases as they come through our laboratory. So we do routinely reflexively test PD-L1. And if we know that we had a high expressor on a biopsy, we'll often stain the resection specimen if we get it, and then use that as control tissue in the future. So we have been able, through really keeping a close eye on our controls, we've been able to perform much better than we were in some prior CAP proficiency testing surveys. And I am very confident in the results of our PD-L1 because we modified that control tissue. So I think it's really important to keep an eye on that. And by having the control set up in that way, you're actually able to even pick up little drifts in staining intensity very quickly and very easily. We run PD-L1 every single day, and if there's something off right away.
Any key takeaways about teaching and training residents when it comes to PD-L1?
The challenge I have with training residents and fellows with PD-L1 is, in the majority of our IHC stains, it's brown or it's not brown. And PD-L1, obviously we tell all of our residents with every single stain, you have to actually look and see what's staining. But it becomes very crucial in PD-L1. I don't know how many times especially with junior residents, a case is brought to me and, oh, this is 99% PD-L1 staining, and guess what? It's alveolar macrophages. So the challenge with PD-L1 is really the specificity of the stain, what is picking up that stain, and there's a lot of confusion. I mean, we know amongst even practicing fully trained pathologists, there's a lot of confusion as to what's the right scoring system. And so we have in our reporting system multiple templates depending on what the PD-L1 assay we're running is. And so sometimes the wrong reporting system gets put into the report, and you have to fix that with the trainees. But it's a challenge. I mean, there's a lot to learn when you're a trainee, especially just learning how to diagnose tumors. And now, guess what? We'll throw some complicated companion diagnostic testing on top of that just to make it even more difficult. But with training, residents come around, and oftentimes by the time they're a fourth year resident, we're about equal in what we're calling. So that's good. But it can be a challenge.
I completely agree with Dr. Schulte, actually, in terms of confusions about PD-L1 testing. There's TPS, CPS, IC, and as residents rotate on different surfaces, on thoracic, on breast, on GI surface, they basically will encounter different individuals with perhaps different observability in terms of how they score PD-L1, different scoring system. So there's a lot of confusion, actually. And of course, I think in addition to realizing when is the lesional cell, macrophages, you should not count macrophages in the TPS, but CPS, associated with the tumor, you should. But also whether do you need complete circumferential PD-L1 staining, or is it partial membranous staining okay, which is okay for TPS. And so I think there's a lot of nuance that without a holistic conceptual framework, I think it's hard for residents to understand, to approach this topic because it's too complicated.
I give a lot of didactic lectures in the residency program. I actually thought about adding a lecture specifically pertaining to biomarker testing. Residents get that information obviously at the scope when they sit down with the individual attendings. But I think as an IHC director at my institution, I would be kind of uniquely positioned to kind of gather all this information surrounding biomarker testing and give a small lecture series on that topic, 1 or 2 lectures. Other thing that I've been trying to implement is actually bringing residents into the validation process. And we did have a resident help us with the last validation we did for PD-L1 and GYN specimens. And I think that resident found that was a useful experience.
It is a challenge for residents, fellows, and also practicing pathologists. Agilent has training methodologies, or call it like images and tutorials. You can go onto the websites for the resources and go through the testing. But what we've been doing is passing on the slides, like pick about 10 slides of the validation set and just pass it around to see how they score, and also just showing among ourselves, like, more than one person to see how this is scored and stuff like that.
Operational perspective, are there things to consider when it comes to running PD-L1 tests throughout the day? And if so, what are some of those key considerations?
At our institution, we actually did have to look into when we perform PD-L1 testing. Actually, we looked at not just PD-L1, but other biomarkers like HER2. And we did that because we had a recent merger with a community hospital here in town. And now we perform the anatomic pathology services for that community hospital. And we also have a very active dermatopathology laboratory that sends us all their histology. And so we had to find space. We have limited space at our institution, and we had to figure out how we're going to be able to turn around our IHC so that we can get our diagnoses out the door, but also perform biomarker testing. So the solution that we found was that we would batch PD-L1s and some other select biomarker tests on overnight runs, and so that they would be available to the pathologist the next morning. And we left it up to our individual pathologist if they would like to hold the case and sign everything at once, or issue an amendment with the biomarker test. We did this in collaboration with our clinical colleagues, and essentially said, what's your expected turnaround time for some of these biomarkers? How long after we make a diagnosis do you need a PD-L1 result? And our oncologists here were very pleased when we said, we'll get you the results in 24 to 48 hours. If you have to remember, most of these tests start as send-outs, and so now they're in-house, and so a 48-hour turnaround just seems great. We do most of them in less than 24 hours. It's usually, sign out your case at 5 o'clock p.m. one night, and then guess what? You have your PD-L1 next morning. So 8, 9 o'clock in the morning, the next day, you have your PD-L1. So that was a solution that worked for us, moving the less critical IHC to an overnight run, which allowed us to get our diagnostic stains out the door the same day.
So this is actually the International Association of Study of Lung Cancer survey. It's published in Journal of Thoracic Oncology just 2 years ago. It's a survey that was given to pathologists throughout the world and asking what kind of PD-L1 clone they use So one can see, in fact, most of the time, at least in the world, 22C3 is the most popular clone for PD-L1, followed by SP263. Within the 22C3, how often are they used exactly as companion diagnostics versus LDT? In about 40% of the time as LDT.
If you were to give suggestions to anyone who's thinking about establishing a PD-L1 LDT, what are some things that you would want to make sure that they remember as they plan that process?
Don't rush it. Take your time and really carefully scrutinize your results you're getting. Make sure you trust whoever you're using as a reference lab. And one thing that I do as an IHC director is if something just seems off, it's okay to ask your reference laboratory to send you slides so that you can actually lay eyes on them yourself. Most will actually accommodate that request. If you make that. One thing that we've also had to do, and don't be afraid to do this either if you're bringing in a new test, I think this goes for really all IHC beyond just PD-L1. If you need to, have a tiebreaker. If you're having some discrepant cases, try another laboratory. If you don't trust your own results, have your partner read them. See, are you matching your partner? So just be careful with your validations. Take your time, do it carefully, and if something seems off, keep digging until you can solve the problem. Don't settle for a mediocre result with your validation. Go for as best as you can. And I think if you do a solid validation up front, do more cases than are required by CAP, maybe throw some weird tumors in there and see how those perform as well, because you never know what the next request will be. So yeah, no rush.
Three important things. Number one is validation, and that the validation process should include all the tissues which have the recommendations as well. But I think all tissue types is generally the best way to validate. Number two is positive and negative controls. You have to use the appropriate positive and negative controls. And the third part is the scoring system. That is scoring for the validation and also among the pathologists, and having a good CAP, ordering for the CAP PT testing as well as some kind of a measure in your laboratory, and also having a second opinion among the pathologists when there is challenging cases as well.
My thoughts on PD-L1 is that at the end of the day, it's a semi-quantitative predictive biomarker. It's a very important thing to get right, which means it really emphasizes the importance of consideration, whether not every laboratory should get their own PD-L1, not necessarily, without some sort of cost, benefit consideration, time analysis, and various things. But beyond that, if you decide to do it, having proper validation and continual monitoring is very critical actually on this.
Thank you for participating in this continuing education activity. Please complete the post-activity evaluation and remember that there are other educational resources on immunotherapy and PD-L1 testing on the ASCP website.